Coming up.
If you're not watching, you should.
There's descending drivers and there's ascending drivers. So I do what I call toes to nose. So when I start with someone, I always start at the feet and work my way up. So you got feet, because that mechanism is so hooked into the sacrum, right? So if you can work on the head as much as you want. You can work on the head until dawn till dusk. But if that sacrum is rotated, strained, it doesn't has some sort of impact on its unconscious mobility and its unconscious movement, you'll have a jam up here. When I hold the feet, so I was talking about the sacrum. So the sacrum's here, the feet are here. All right. So if the sacrum's doing that, the legs come out here, right? So when you got the foot, you got holding the ankle, and that's doing that, you can actually feel that expressed in the leg, in the foot. Yeah. So what that is you're holding a long lever on the sacrum, but you got to correct the foot. That's how powerful it is. Because look, there's arches here and there's arches here. Why do we have arches? Because they're nature's strongest force absorption design. Yeah. So an arch is way stronger than a V, as we know. Yeah. So if you're chewing, you want to dissipate that force through the skull. If you really want to know stuff, that's what the maxilla does. There's like 32 other bones in the head. But what the arch form actually does is act as like what we call, Sutherland called it a speed reducer. So watch, if I chew down on here, or I've got force coming from here, yeah, see how that springs all the way through the mechanism? And if that's like that, there's no spring in the back end. And the back end is your occiput, yeah? And its relationship, there's a thing in the middle where the occiput joins the sphenoid. So it's like a fulcrum for the movement of the skull, right? So what the arch does here in the maxilla is it distributes that force throughout the system. Yeah, so it doesn't clamp up the back of your head. But if you...
We have a special offer for our Munch Bunch listeners. To book a virtual consult with Megan, she's offering a discount of $25 off. Just email her, Megan, at nwmyofunctionaltherapy.com or through her website, www.orofacial-myology.com. To book a virtual consult with Kimmy for the $25 off, email her mouthmusclememory@outlook.com or through the website, www.mouthmusclememory.com. Now on to the episode.
Hi, everybody. Welcome to the Munch Bunch podcast. It's Kimmy Nishimoto and Megan Van Noy.
Hello.
And we have our friend Cole Clayton, who is an osteopath in Byron Bay, Australia. Say hi, Cole.
Hi, everybody. Hi, Kimmy. Hi, Megan.
Hello.
Thanks for having me. It's good.
Yes, happy.
Good time of day. It's Australia Day today down here.
I know. Cole's he's in the future, you guys. So he's a whole day ahead of us right now. Which I mean,
like it's our national holiday. It's Australia Day. It's like Thanksgiving, but Aussie style.
I love that. And then you took today to meet us anyway. So thank you.
Thank you. What do they eat in Australia on Australia Day? Is like emu or ostrich or
Vegemite?
It's barbecues. You have to have a barbecue today.
I love it.
Yeah.
But do they say barbecue or the barbie?
Yeah, is that true or is that actually a rumor?
Yeah, but the accent was pretty interesting. If you want a real Aussie accent, Kimmy say like, "Yeah, we're gonna have a barbie today." How's that?
That was really good. That sounded very Australian.
Bring the beers. We're gonna have a barbie. Yeah, woo! Australia Day, rocking. Yeah. Anyway, off topic.
It's beautifully on topic, truly. Okay. Speaking of, we are going to pull our affirmator for the day. I've got all of our cards here with us. All right. So, Cole, you're going to tell me when. I'm going to shuffle through, and you say when.
Wow, this is like tarot or something. Go now.
Okay. Ooh, okay. Roots. I think this is going to be a good one because we are talking all about the body today. So roots, I remember where I came from, for better or for worse. I'm grateful for the person I've become, either because of or perhaps despite my upbringing. As I move through life, I keep growing and changing, but I can marvel at the magnitude of my journey without reflecting on where it all began. I love it. I love it. So speaking of roots, we got to meet, actually, Cole is actually a part of mine and Kimmy's origin story, you guys. I don't know if he knows this or not, but the whole reason that Kimmy and I met is because we were representing Munchie at a conference in San Francisco. And then we met Cole through some training with Munchie. That was kind of a former hat that he has worn, and now he's specialized in becoming an osteopath, and I will let him speak more about that. But and has his own practice, like Kimmy said, in Byron Bay, Australia. So Cole, tell us a little bit about you and your background and your journey, and then we're going to barrage you with questions.
Okay, cool. I can be quick about that. So when I was a kid, I had SDB, but that was the 80s and nobody knew. So I went through certainly like what you'd call grade school, or we call primary school. It was pretty okay. But then when I hit high school, like brain fog and, just all the stuff, snorings and apneas and all that, totally undiagnosed. Everyone just said he's lazy. Like, he's pretty smart, but he's lazy. So I didn't do that good at school. Not that it wasn't like disruptive. I tried, but I just couldn't do it, And so, but I got really into art, so painting and drawing. And so I used to do a lot of art. I used to spend a lot of time in the bush doing art. I was a bit of a loner as a kid. And then I went to art school as a university, because in our family, talking about upbringings, you didn't not go to university. It was just like, what course are you going to do? Not, are you going to go? But yeah. So I did. I studied art, and then after, I was into sport as well, because usually, you guys probably know, when you've got SDB, like a lot of some way people go is get right into sport and exercise, which is what I did. But the problem with that is you don't recover very well, so you end up sick, which is what I did. But then I got into exercise and personal training, and then corporate health promotion, and I had a bit of a corporate health career, actually. So that's like wellness programs for people in large businesses, and functional training and functional exercise rehab. Then had like a midlife crisis at 28 and threw all that away, and traveled for a couple of years, and then came back and eventually what was I doing? I kind of tried that many things to be well, and I just never quite got well. And then I was just about to give it up. I was about to give it up and go and mow lawns and clean gutters and do maintenance stuff, because I was just like, I can't do this anymore. And I met a dentist, actually, of all things. We were talking about dentists before. I said, no, I'm giving up. And he kind of looked at me and he goes, no, you're not. Like, it was really intense moment. He's like, no, you're not. I was like, no, dude, I am actually. He's like, no, you're not. So he said, come and watch me in my practice. He was pretty on, old Tony, and he's passed away now. Tony Ansell, if anyone listening's ever heard of him. Really left of center thinker, really progressive thinker, and voracious learner as well. He learned that much stuff, did that many courses. But he sort of showed me some stuff, and he goes, you know what it's about? It's about airway. And then I was like, that's really interesting. And then I did some breathing work, like a course with him. And we went to this breathing course together, and I was like, that's me. That was me. All the symptoms, when you have those moments, I'm sure anyone's been and had those moments, you go, whoa, geez, that's all me. That was all me as a kid. No wonder I can't think straight. So I fixed my breathing, right? But I was like 34, 30, maybe, about that. And I fixed my breathing, and then my brain started to work. And then I was like, oh, I can do all this stuff. I can have a career. And, I never actually had that proper perception. And it brings, when you fix your breathing, and it opens the solar plexus, your power, your energy comes in. You go, I can be me, like this is cool. So then I kind of got to the point, I started teaching kids breathing, and then I learned some OMT off Sandy Coulson. She came down here a couple of times, and I was starting to sort of be introduced to that world and this field. And then I was like, well, I finished a master's degree in health and clinical rehabilitation. And then all of a sudden I was like, yeah, well, I kind of need to get a career, like a qualification now. And I was like, I should have done this when I was 25. I couldn't, because I couldn't think, right? So there's the lesson. Yeah. So that's why I'm passionate about teaching this to people and getting the word out there, because it's way easier to do a degree at 18 or 19 than it is to do it at 38 when I started. So anyway, I was like, well, hell, if I'm sitting here in 5 years and I haven't done it, I don't think I can sit with that person. So I just opened the computer and applied, and then just went and did 5 years of tertiary and graduate and postgraduate education, which was not fun. But then in the end, I finished, and I was lucky enough to work with Munchie along the way, like pretty much for the whole 5 years I was at uni. Mary gave me a job, and which means it's cool because there's more learning. And so I kind of had a career, but I had to then get the qualification to meet of what I wanted to do, as opposed to sort of most people do their qualification and then get their career. So basically, in a nutshell, my story is back to front, upside down, topsy-turvy. But Mary reckons that's how come I kind of have a different view on things, perception on things, or can understand things differently, because I always do them the wrong way around.
I like it.
Yeah.
So now, that's what I do. I focus on general, mostly cranial osteopathy, but I see a lot of kids, breathing, OMT stuff, and craniofacial osteopathy, basically. It's fun.
And for our listeners, what is cranial osteopathy in like simple terms?
Yeah, that's really hard to explain in simple terms, but it's like, it's basically there's a guy who studied with the founder of osteopathy, and his name was W.G. William Garner Sutherland. And Sutherland kind of had a moment where he looked at a disarticulated skulls, or skulls all broken apart. And he had a voice in his head that said, beveled like the gills of a fish, built for a articular respiratory motion, or something like that. That's probably not the exact words, but this is like a famous thing. He called it his Tom Fool moment. And he went, no, that's not true. Like, the skull's fused, it doesn't move. And then he spent 30 years investigating whether or not that could be true. Like, literally, he was still practicing, but then he'd go home and he'd sit there and like disarticulate skulls and look at the joints and do experiments on his head with like baseball gloves and football helmets. And he almost killed himself a couple of times doing it. And he basically figured out cranial theory, which is that, the cerebral spinal fluid moves. It's involuntary. It has a movement, fluctuation. And with that, so too does the sacrum have a mobility, which is involuntary. Yeah. And then there's a motility to that. So there's an inherent movement to that ebb and flow. And that the cranial bones move with the sacrum to help facilitate that. So, and then there's a deeper layer to it as well, which is kind of like, he called it intelligence with a capital I, moves through the cerebral spinal fluid. So or they sometimes call it like CSF is the seat of the soul. So it's like there's the depth comes from like, once you get that mechanism moving, and we kind of spend a long time learning how to feel it, a bit like a Chinese doctor would feel your pulse and go, spleen energy's low. Like, what? Like, we kind of feel from the feet and go, oh, what happened to your left shoulder? And people go, what? How do you know that from my feet? It just takes a while to be able to palpate that mechanism and feel where it's not expressing itself. So the idea is to express the mechanism. So if you get someone's cerebral spinal fluid and that mechanism, craniosacral mechanism expressing itself, guess what? Their whole body expresses itself, including its ability to heal itself. So I'm not saying you can take a stage 4 cancer patient, put them on the table and magically, get them to heal their body.
Right.
But you can do a lot with someone who's had like lots of bumps, accidents, strains, sprains, head injuries, and kids, because kids have generally, birth strain through their system.
Oh, yeah.
So you can treat that. And a lot of the time it's birth strain that creates a lot of these craniofacial malformations. So by treating that in children, those strains, you can actually get the mechanism to express, and then boom, you've got this full potentiated being, so that's really the crux of the philosophy of osteopathy in the cranial field. In osteopathy, some people think that's a load of woo-woo nonsense, and other people are like hardcore into it. And then there's people that dabble kind of in the middle of that and use it a bit, and there's a spectrum of that. So I kind of sit over here. I'm not hardcore, but I use it a lot, but I also do other things too. Yeah.
And do you only focus like on the head, or do you do manual manipulation of other parts of the body as well?
The whole thing. So I do what I call toes to nose. So when I start with someone, I always start at the feet and work my way up. So you got feet, because that mechanism is so hooked into the sacrum, right? So if you can work on the head as much as you want, you can work on the head until dawn till dusk. But if that sacrum is rotated, strained, it doesn't has some sort of impact on its unconscious mobility and its unconscious movement, you'll have a jam up here. So you can't. It doesn't matter how much you treat the head or what even devices you put in the head. If you've got a sacral strain, nothing's going to happen until you release, until you free that sacrum up, and then you got to figure out why that happened and what else has suffered from it. So yeah, I spend a long time actually, Kimmy. Like most osteopaths, like will work a 40-minute, 30-minute session. My regular session's 60 minutes. And when I see someone first up, it's an hour and a half, because I tend to just try to figure out exactly what I need to do to get the most potent thing. So like out of all the different potential like things in a diagnostic sieve as such, what can I treat that's going to get the most result for this person? So you can treat, a knee for 40 minutes and the person walks out, they go to sleep or they walk down the street, whatever pattern was driving that knee will be back. So that's probably better for business. My business model is probably not one to reproduce. But
I love it though. So, what I think is so interesting is kind of what you said, you start from the feet up, which is, I feel so different, especially from kind of my experiences with bodywork, is usually they kind of start from the top down. So, in your experience, why start from the bottom instead of starting from the top?
There's a couple of reasons. The two main reasons are, firstly, when I hold the feet, so I was talking about the sacrum. So the sacrum's here, the feet are here. Right. So if the sacrum's doing that, and people will tell you it doesn't, and you can never feel it even if it did, which is fine. But the legs come out here, right? So when you got the foot, you got holding the ankle, and that's doing that, you can actually feel that expressed in the leg, in the foot. Yeah. So what that is you're holding a long lever on the sacrum. So you can get a really nice idea. Well, I can get a really nice idea of what's going on with the sacrum, even if it's moving, if it's like, sometimes you'll feel like one side right up, sometimes you'll feel like a big oppression on one side. So that gives me a general read. It also gives me a general read on the person's vitality. So that rhythm, is it strong or is it really weak, or is it trying to express and it's not expressing. So there, and then straight away, one of the first things I like to do is look at the talonavicular joint. So the talus and the navicular articulate. And if you've got your anatomy, if you imagine the arch of the foot, the apex of that arch basically is where that talonavicular joint is. And so the apex of the arch, just like on a cathedral, is the most load-bearing. It has the capacity to do the most load bearings. That's why foot arches are so important, right? But if that joint, you can't voluntarily move it. It moves, it articulates via the movement of the foot. So as we strike and walk through, So if that joint doesn't move, right, then you lose a lot of the articulation of that joint actually creates a deceleration, acceleration, wind up across the apex of that arch. Makes sense? So basically, if that joint isn't moving, you're inefficient in gait. And so then what happens? Well, you have to twist your foot a little bit more. You have to get more torque through the knee, which means that's going to go up to the hip, which means that you're going to then wind up more through the back, the fascia of the back and the muscles, more so the fascia, but the muscles and fascia of the back. So you have this like little bit of a asymmetrical driver in your gait. So that little joint is really important. And I do a few little things that I kind of have developed. I'm sure I'm not the only person that's done it, but I never got taught it. I just kind of made it up, but I do a few little things, and then you can basically, often that joint will do a little cavitation and then boom, it's starting to move. And people often just go, oh, whoa, what was that? It can be a big thing. So that's the two main reasons I start on the feet. One, to check how that mechanism is feeling from an osteopathic point of view, and two, because I want to check both right and left, that joint, the talonavicular joint, really important. Apex of the arch. When you consider the size of that joint and the weight of a person standing on it, like the mechanics and forces of that are just like, they're mind-blowing.
Yeah.
So going back to the arches, some people have really high arches and some people are flat-footed. What are common things that you see with someone who's flat-footed versus who has like an extra high arch?
Yeah. Well, typically, like everyone's kind of somewhere in that spectrum. The most important thing is to be able to see what it's doing actively. Okay. So if they're just standing there and you go, oh, wow, look at that, Megan's got flat feet,
Which I do, by the way.
How
did you know? How did you know through the screen?
That's just because we haven't treated you yet.
That's right. I'm hopping on a flight soon.
Yeah. Well, we know that. No, I am. I'm coming to your retreat. So we know that. Oh, now I lost my train of thought. I was thinking of your retreat. We know that if you program your brain to tell yourself you've got flat feet and that's a bad thing, that every time you do, you'll actually send an inflammatory signal from your brain to your feet. Did you know that? That's proven.
Oh, that's so interesting.
So we're not going to say that anymore.
I love it.
Yeah. And for two, you got to have a close look at what's defining a flat foot. And that's a whole sort of anatomical discussion. But what the point I want to make is whether you're really high or whether it's really flat. And I will just comment a little bit in a second, if you remind me, on genetics and flat feet, particularly people with Asian heritage. There's a really interesting caveat to flat feet in people with Asian heritage that's worth noting, because it happens. Have you ever heard that? Like people go like, oh, I've got, flat Asian feet or something. Like my mate's Filipino and he said that. And I was like, nah, dude. So what it is typically people with Asian heritage will have a fat pad along the arch of their foot. Yeah. So it looks like when they're standing on the ground, it looks like that their whole arch, their foot's contacting the ground, but it's not. It's actually a pad of subcutaneous fat that sits there. So it must be something to do with like ancestral, requirements to have that there. But it's really common. Yeah. So don't be fooled by that, because what you really want to know is not what's the foot look like statically. You want to look at what the foot does functionally. Okay. So to do that, you have the person stand on their toes. What's their flat foot? What's that do now? Well, you get the person to stand on their feet, lift up their toes, dorsiflex their toes, especially the big toe, the first toe. Oh, what happens to the arch then? Stand on their heels. What happens to the arch then? And you actually get the navicular tuberosity. So there's a little bump on the bottom of the navicular bone, that sits inferior to the bone itself. And if you measure from the floor to that bump, it should be like a centimeter or so. But if it's really close to the ground, that's probably a true flat foot. And a true flat foot is essentially a foot that's in eversion, which involves a number of movements in a number of joints. And what happens there is you'll usually find a heel bone, the calcaneus, gets jammed in to an eversion position, or it won't evert at all and it goes all the way into inversion. So then you've got this whole collapse through the system.
Is that where your feet kind of like roll inward?
Yeah, that's it. So, they might be sitting like this, and then instead they'll go like that, to the ground. So they'll start doing this sort of thing. And then you'll see heaps of shoe wear on those type of people. But you have to sort of see what happens, because the active position of the foot is what happens during gait. So don't just look at my feet and go, right, you've got flat feet or foot orthotics, $1,500. It's like, nah, let's have a look at what happens to the foot when we actually use it. Because when we're using it, that like, it doesn't really matter what it's doing when you're sitting. Nobody really needs it to be perfect when you're just standing still. But then you've got all number of different things that come into play, and the biggest driver is going to be what we call Norton's toe. So you imagine this is my foot, that's my big toe, it's like the second toe is longer. So you start looking at that.
I got that.
You got it.
I'm like, wait, where's my toe?
You're like, oh, let me scoot back, let me look at my toes.
I got 2 patients out of this already. So what happens there is that's actually a sort of a thing that happens where the talus fails to fully unwind. So as embryologically, as that bone, all bones come down and do a sort of a twist through like this. And as it's not unwound all the way, and you sort of end up with this scenario. And what happens there is that big toe should hit the ground first, right? And then you pronate, and that decelerates you, and then you get to a certain point in that, and then you supinate, and that accelerates you. But if you're short through that first one, you'll overpronate, and then usually you'll get a little twist to try and like a little extra muscle work to try and push off through here. And that, what I was talking about before, there's descending drivers and there's ascending drivers. Well, that little extra pronation and that little extra twist creates all sorts of havoc up the chain. And it absolutely changes breathing. And I can promise you that, because the treatment that we use is super simple. It's a neurological insert that goes just under that first ray of the foot. And when I started using that, all of a sudden I could run. I used to run and get a sore neck. It's like, what the heck? Why would you get a sore neck running? Like, it used to go into spasm. I was like, well, it's because I was overpronating, and that's affecting pelvis, that's affecting diaphragm, and then you're over breathing up here. And it's totally wrecking your posture. So I wore these corrective insoles for a while, and they're a super simple thing. And I started getting sore glutes and hammies and calves from running. I was like, yeah, this is more like it. That's what should be sore. So that little thing, that Morton's toe, is really worth having a look at, because especially in the kids, you'll notice where there's problems, especially asymmetrically in the jaw with tooth placement. So you usually, like, if there's a real asymmetry on the right or the left, let's say in this case it's my right, if the foot's like that in a kid, then I guarantee you probably like their first molar will probably angle in the same way. Yeah.
So weird.
Yeah. Yeah. And then so you can put a braces on that, and then they get the braces and then they take them off, and then all of a sudden that damn tooth is like not straight again, you know? Yeah. But you got to correct the foot. That's how powerful it is. Because look, there's arches here and there's arches here. Why do we have arches? Because they're nature's strongest force absorption design. Yeah. So an arch is way stronger than a V, as we know. Yeah. So if you're chewing, you want to dissipate that force through the skull. If you really want to know stuff, that's what the maxilla does.
So
everyone bangs on about maxilla width and all this stuff. It's like there's like, maxilla and mandible, right? Oh yeah, the relationship. There's like 32 other bones in the head.
That's true.
What are they doing? That's what I want to know. Right? Don't just focus in on this one part of one bone. That's not even the whole bone. But so what that arch form does and why it's so important. Yeah, tongue space, I get that. Yeah, airway, I get that. Important. Not denying that for sure. But what the arch form actually does is act as like what we call, Sutherland called it, a speed reducer. So watch, if I chew down on here, or I've got force coming from here, yeah. See how that springs all the way through the mechanism, and if that's like that, there's no spring in the back end, and the back end is your occiput, yeah, and its relationship. There's a thing in the middle where the occiput joins the sphenoid, yeah, big words, sphenobasilar synchondrosis, SBS, yeah. So it's like a fulcrum for the movement of the skull, right? So what the arch does here in the maxilla is it distributes that force throughout the system. Yeah, so it doesn't clamp up the back of your head. But if you don't address that when you're working on that little arch over there and the rest of the bones around it, makes your job way harder.
So interesting.
Yeah.
It's so interesting.
I'm so driven to say that.
Yeah.
That is
I think about it all the time.
We want to introduce the spot for Tots Course, a parent's guide for toddlers ages 2 to 5 for mini myo. We have Megan and Kimmy going over nasal hygiene, myofunctional exercises, breathing exercises, tongue-tie healing protocols, and then we have Jenny June going over sleep hygiene, and Kelsey Baker going over feeding therapy and body work. The course is $297, and the link will be in the description.
It's so great to work with somebody like an osteopath who really looks at the whole body and doesn't just kind of like microscope in or zoom in on just one space, because it is, like, we say this all the time, right? The whole body is connected, but in Western medicine, that's not necessarily how it is studied. And so then as we kind of move through the system, it's like everything is, in its own little corner, when really everything has to be working correctly in order for there to be like, what do we call it? Homeostasis, symbiosis, whatever you want to call it within the body.
It's synergistic, isn't it? So it's like a system of systems is way more greater than a system.
Right.
And I know I talked about this on the Munchie one, but if you think about it, like a closed chain versus an open chain. So if I like get a weight and I lift up the weight, then I'm overcoming that resistance. Yeah. But if I walk across the floor, I'm not going to push the earth away from me. I'm going to move across the earth. So that's a closed chain movement as opposed to, an open chain movement. Does that make sense? So we have those, it's a fixed position that we can't overcome. So we have that in the foot where there's an arch. Where else do we have a fixed position we can't overcome where there's an arch? occlusion. You can't bite your teeth and split them apart unless you let your oral health go. Yeah.
Right.
Typically, hopefully. And as you know, when you get occlusion right, like the whole body strengthens. Yeah? So it's like those are the two places we have a fixed closed chain system. And those two, as I've said before, as I was just saying, they totally relate. Yeah. And then what have you got in between? You've got so much in between of there. Yeah. You got your brain and eyes and jaw above it, but you've got like neck, tongue, you know, you've the sling under here, you've got your diaphragm, your lungs, your pelvic floor, your internal viscera, you've got your knees, your hips, you know, and your ankles. It's like it's there's your everything's connected. It's and the whole system. It's not like that you just work here and you don't affect down there, and vice versa. The whole system's like doing this continuously because that's how we formed. We formed as one organism by doing this, and then moving to space, moving to space, moving to space, moving to space. Wow. That's how we got here. So the treatment, like your modality, that's what you want to do. You don't want to push something to grow. You want to create a space to allow it to grow.
Wow. So many knowledge bombs in this episode. Cole, I have always wanted to know this answer to this question. What is the connection between like a lazy eye and oral dysfunction or tongue tie?
Wow. So you're really testing my anatomy here. So the abducens nerve,
or is there a connection? I guess.
Yeah.
Well, no, you know, if you ask enough people, there's a connection between your auntie's, you know, pancreatic disease and tongue tie. I don't know, like it's like anyone can link anything to tongue tie. Okay. But I'll link it to the brain. Give me 1 second to the skull. I've got to get one. I'll go and get one.
Is it more of like a cranial strain or like a cranial nerve?
That's what I'm going to show you. Yeah. So the abducens nerve, which abducts the eye, right? So brings it this way. That's what I was saying about it. Don't test me on anatomy because I can't remember that. It's like the rectus something in the eye that does that pulls the eye out. Yeah. So you know, I was talking about birth strain. So as this is an adult skull, but as it comes through, it gets compressed and it turns. Okay. So you can have all number of things happen in that process. But if you grab a temporal bone and you take it off, that's the part of the temporal bone we see. But if you turn it the other way, it goes right into the head, right? Okay. So this is called the petrous portion of the temporal bone. Okay. And that abducens nerve runs right over here. Yeah. So if there's a strain in that system, which there definitely would be in that kid, if there's a strain in that system, you can have the quote unquote lazy eye because that nerve that runs over that part of the temporal bone can get impinged basically and slightly inhibit the muscles at that end. So then you might say, well, hang on a second, what's that got to do with tongue tie? Well, basically nothing, but it's got to do with the function of the tongue, okay? Which in my world, don't get me started on tongue tie because we don't have time today, but in my world, see this. See how well, too bad if you're listening, but see how
they'll watch it.
The bevel goes under here, but then it switches and goes over. Yeah. So that's in here is the occipitomastoid suture where that bevel changes, and that gets really compressed most of the, like in a lot of people. So if the temporal bone's having a dysfunction, you're guaranteed to probably have that, which will then affect your occiput. Okay. Now here's it. I'll test your anatomy. What's important about the occiput relative to the tongue from a cranial nerve point of view?
That's where most of the cranial nerves come out, right?
Yeah, but specifically for the tongue.
Oh, hypoglossal?
Yeah, exactly. Cranial nerve 12.
Crushed it. You crushed it.
Cranial nerve 12 comes out the base of the occiput,
Yep.
wraps around and innervates part of the tongue. Yeah.
Mhm.
So if you've got a compression through here that's affecting the temporal, it could affect that cranial nerve 5, but it could also affect 12. And so if you're linking lazy eye and tongue, my answer would be you probably got a strain on the left side of the skull.
Question
Yes,
as
ma'am.
well. So that part that you just showed where it's like the temporal meets the occiput. So a lot of people with tongue tie also have a lot of tension in the very back of their head, and the
do.
base of the head and neck. What's the connection there?
Well, the connection is we see what we treat and treat what we see. So what you're looking at when you look at your tongue ties, you're looking at a midline structure. Okay.
Right.
So we develop from the midline out. Yeah. And things are asymmetrical to the midline. So your liver is kind of crosses the midline, but it's skewed to the right. Your lungs are a different shape on the left to the right. Yeah. And that's set up because of those rotation forces that are embryologically develop us, but also that serve us all the way through life. So, your Achilles tendon is spiral shaped. Yeah, like your blood doesn't go like this, right? Blood goes like this. It spins. Muscle cells, like the fibers, they're not straight.
Mhm.
They're spiraled. Yeah. How else do you think we get contractile tension at such forces, magnitudes through things? You can't do that if it's just like a straight pump. It's not going to work. It has to have a tensile nature to it. Yeah. So that all sort of come back to the midline. That all kind of stems from this notion of having a midline. It's not like there's one specific structure that is the midline, but when you're looking at the tongue, and specifically the lingual frenulum, you're looking at a midline structure. So let's talk anatomy again. What other midline structures are there in the body?
The spine.
Yeah, but what part of the spine? Because it has some right and lefts to it.
Megan, I call you.
Oh, I was going to just say the spinal column is where I was.
Yeah. So that would be one. The spinal cord would be one.
Yeah.
Even though it's still got branches, but through the middle, that's where the CSF flows. So that's like our most important fulcrum, one of in cranial osteopathy. What about the folks that runs through the middle of the brain, part of the dura?
Okay.
And the dura runs down the spinal cord. Yeah. What about the central tendon of the diaphragm? The way it coils and round on itself and the diaphragm sits like that. Yeah. Central. Yeah. So these are kind of other midline structures. What about the raphe of the mylohyoid, where that comes together? What about the linea alba? Yeah. What about there's fascial connections through the pelvic floor.
Right.
So all those are midline structures. So what you got to say is, okay, what's going on through this person's midline that's driving all that, coming back to Kimmy's question, all that head, neck, jaw tension? Is it simply just because that one piece of anatomy is tight? And what's that one piece of anatomy relative to? Well, what's relative to what we call diaphragms? So you've got your tentorium underneath your brain, right? You've got, I call the diaphragm, I call the fascial and muscular sling on the floor of mouth. That is a really important diaphragm to me because of the nature of the kind of ascending and descending musculature system and fascial system underneath it. So when you're looking at tongue tie, that's super important, right? Because of the function. So if it's kind of like what came first, the chicken or the egg. So if you've got a bunch of compression strain through that occiput, okay, and it's pulling right down like that, you're going to have a bunch of strain underneath here in those muscular slings, right? And so if that's a midline thing, well, then let's follow that all the way down and get to two other diaphragms. One would be the thoracic outlet, the other is going to be the respiratory diaphragm, and then you've got pelvic floor, you've got knee ligaments, and the plantar fascia. Now we're back on the foot. So you've got all those diaphragms that are kind of hanging off midline structures, and they're kind of doing this. You see that? So the lingual frenulum actually happens to be one of those midline structures. So if that whole system is kind of doing, instead of doing this, if it's doing this, what's going to happen to the tongue, right? The tongue's going to be restricted, right? Until you free up all that. And then you go, okay, now let's look at the tongue. Once all that's, I just call it squared up. Like once all those diaphragms are square and functional, how are you using your tongue then? Let's have a look. Yeah. And that's when you can sort of go. And what I look at really closely is the relationship. So, we all know our tongue range of motion assessment, Dr. Z's, tongue range of motion ratio. Yeah. But what you got to strongly look at is the quality of that ratio. So if your full open is like, I've got his face off here, sorry. There we go. It's a bit old, this thing. But if your full open is like 55 and your tongue up is like, well, let's make it easy math. It's 50 and your tongue up is like 20. You see how the quality of those two is not that great. Yeah, it's easy to do the sum because it's like a 40%, and then you go, whoa, tongue tie snippet, right? So it's like, yeah, but hang on, the quality. Megan got it. The quality of that ratio is not good. Yeah. So I would then go, okay, let me see what happens if I firstly prepare the body for that kind of treatment. So that's treating the cranial, but it's treating toes to nose, and it's ending up here and treating, Kimmy, all that compression that you're talking about. And when you've got compression through the occipito-atlantis joint, so C0 and C1, right? All the way through the neck, you're going to have problems because you're probably going to have a rotation with that as well. So you're going to got to get all that squared off. If you can get some fluid into the back of the head and the occipito-atlantal joints moving properly, right, and reasonably symmetrical, then you can get in and you can work on. Externally, I work on mylohyoid, submandibular muscles. Yeah, I work on those externally first. Get the temporal bones working, and only then I look at the tongue. I go to the tongue then. Yeah, and then I'll actually get in and release the fascia, because what we know from Nikki Mills' great work is that the floor of mouth is a fascial sling, and the lingual frenulum is the midline structure of that fascial sling, right? That's a really important point to get. The lingual frenulum is a midline structure of the fascial sling. Yeah. So what are you going to do with breathing dysfunction? Go surgery and cut the central tendon? That wouldn't be what I'd do first, right? I'd get the whole system functional as we can. So I actually end up anteriorly and then posteriorly manually releasing that fascia. And then I have a look what difference that makes to the jaw and the tongue range. And what you'll find, what I normally find is, unless I'm really off or there's something else going on, is that ratio will improve a lot. So I saw one the other day who started out like more at that 40%, and then we got it to like 40 total open, the total open reduced, and her tongue up increased to 30. So she was then sort of a 75%. It was 30 into 40 as opposed to like 24 into 45, you see? So that ratio gives you an idea of how the function of, remember I said it's not just this bit, there's all this bit too. Yeah. So that gives you an idea of the function of how these relationships are relative to the soft tissue. And so then if you can really look at that, then okay, if you watch that for a couple of months and see if you can improve it and see how you use all your exercise and stretches 100%, and then you keep working and watching what happens to the skull, and it still doesn't change where you want it, then you go, okay, let's look at this. This might be something that's good for you to do. Yeah, but you want to get all that function right first.
Yeah. Oh man, so many cool knowledge points, and thank you so much for showing us the school. I learned so much about the school I didn't know about.
Yeah. Mm-hmm.
Cool.
Honestly, you guys, if you're not watching, you should. But the other thing I was gonna say, anytime Kimmy and I have ever talked to Cole, we learn so much more than we ever like even thought we were going to learn that day. You are definitely one of the smartest humans that we have interacted with.
I'm not smartest. I'm the most stubborn, Megan. I'll tell you that much.
All right, we'll put you into that category too. So
even one of my teachers came here the other day for a treatment from uni, and she said, "Cole, you just kept showing up. You just kept showing. You just kept turning up." I was like, "Yeah, I'm stubborn."
I love it. So, if people wanted to find you on social media, how would they find you?
I was going to make a diaphragm post, but that's just Cole Clayton, Osteopath. So
perfect.
if you want to come and follow me there, I'll try and do some more posts. You know,
there you go.
And then website's just my name, coleclayton.com.au, and that's about all I got. I'm a secretive guy that just sits in this little lab here and holds people's heads. That's what I do. But I'll try. Yeah, but you can also, like, for practitioners.
Mm-hmm.
Have I got like 2 seconds to do a plug?
Yeah, please. Please, this is the perfect time for it.
Plug. Yeah.
Yeah.
Well, one of the things that gets my goat is this whole breathing thing, and people like do all these different techniques of breathing, but they don't actually come back and go, hey, how is this person actually breathing to start with? Like, what's their baseline breathing actually? What is it? Yeah. And so I developed this course called Baseline Breathing for practitioners, coaches, breathing people, just to give like a really clear understanding of what you're actually doing. I got annoyed because friends of mine were doing breathing stuff and then asking me why the person's passing out. And I'm like, you need to know this if you're going to teach it. That's why I built it. But it's quite extensive. There's about 40 videos, but they're all short. They're like 5 to sort of 10 minutes each, and it sort of breaks it all down. And so someone sort of has done, one of the people that did that first round of that training, she said, I've done like a lot of complex breathing training, but I never really got the complex stuff till I did that. So it just gives you the basics, like what happens if you breathe fast? What happens if you breathe slow? So if you do Wim Hof, what happens? If you do Buteyko, what happens? So who needs which one? Because sometimes this person needs Buteyko and this person needs Wim Hof, or vice versa. How do you know? If you're just selling one technique, if you're just getting people to walk around the room holding their breath, then like, what's that doing and how's it affecting? But like, what's their diaphragm doing? How's their neuroemotional state? So this just kind of lays out that stuff for practitioners and shows you what you do, what's happening if you, depending on what technique you do and why you would then choose a technique. So you can find me on that and get thoroughly, bored watching me 40 videos.
I love that. I think
that's amazing.
How can they find you?
Yeah, that's on my website. So coleclayton.com.au in courses. There's only one course up there at the moment. There's a heap more coming this year, but the baseline breathing is under the courses. And it's just an online. Well, it's not just, it was a big thing. It's an online piece. And you can also have calls and contact with me with that.
So cool.
In that part of that program too.
Cool. Yeah, we're gonna have to look at that. Sounds awesome. So people ask us all the time about breathing courses and what's the best way to do it and all these things. So I think that is like such a great needed connection that has not been around. So
before you jump into your big full-on brand name course, just do that one so you know what the heck it's all about.
Yeah, that's perfect. I love it. Well, as you guys know, you can find Kimmy and I at the Munch Bunch podcast on Instagram, the Munch Bunch Myo podcast on YouTube, and you can find us individually. You can find me at NWMFT, and you can find Kimmy at Mouth Muscle Memory. We will link all of Cole's information into this episode, and we hope that we get to catch you guys on the next Munchy Monday. All right, bye.
Thanks a lot. I'm going to go look you up on Instagram.